but I'll be speaking on who needs what operation for constipation in 2019. I have no disclosures. So similar to Dr. Thorson's first slide, I think when you're talking about constipation, you need to decide what is the problem. So you have the patient who says, I haven't pooped in a week and I feel like I'm going to explode. Or you have the patient who says, I'm not constipated at all. I just sit on the toilet for 20 minutes several times a day and I know all the current iPhone games that are popular. So constipation varies, and so I think your approach needs to be tailored to the findings on testing. So for each type of constipation, we'll go through some imaging, testing results, talk about what the data is behind the recommendation for what type of surgery to perform, and then talk about what I think the recommendation should be. So here's the good old SITSMARK study, which I probably haven't ordered in about 4 to 5 years, but you can see the markers are distributed throughout the colon, so thus this is slow transit constipation. And it seems like this would be the ideal type of constipation for surgery. So if you just make the colon shorter, you'll absorb less water and you'll have more bowel movements. And then everybody's favorite, your patient is cured. And there is some data initially that these did have good results. So in 18 patients who had a subtotal after they had normal rectal emptying, 15 ended up having 2 to 6 bowel movements per day, which would seem like a good frequency. And in a study out of here at the University of Minnesota, a survey study of 95 patients who had a subtotal for slow transit constipation, 81% were satisfied with their bowel movement frequency and 93% would do it again. So I think it's pretty hard to find an operation where 93% of the patients would want to do it again. And then supposedly you can even do this even if their pelvic floor doesn't work. So there was a study that showed that patients who had an ileorectal anastomosis, the 41 patients who also had their pelvic floor not working actually had similar results to patients whose pelvic floors worked normally. But I think all of this needs to be taken with a grain of salt. So after ileorectal anastomosis, in one study, 17.5% of patients required conversion to a different operation because they had poor results. And a lot of these patients sometimes have small bowel obstructions because they have global slow transit. Even in the study from here at the University of Minnesota that had such good satisfaction with the procedure, there was actually no relationship between the frequency of the bowel movements and the patient's GI quality of life score. So 41% still had abdominal pain after surgery, 46% had diarrhea at least some of the time, and 21% were incontinent. And then it gets even worse looking at this data out of New Zealand. After an ileorectal or subtotal, half had abdominal pain, 75% were bloated, half were straining to defecate, and half were incontinent. So I think in general, pretty poor results in terms of improving symptoms, even if the frequency of bowel movements goes up. And so I think the answer for slow transit is to strongly consider an ileostomy. This allows you to evaluate whether the transit through the small bowel is normal. It also allows you to evaluate whether the patient's symptoms get better. So if you do an ileostomy and they still have abdominal pain, bloating, they're miserable, it's probably good you didn't take their colon out. It's also very easily reversible and a very straightforward operation to perform. I think if you do an ileostomy and they have relief of all their symptoms and they're a good surgical candidate, you could consider subtotal colectomy or a total abdominal colectomy with ileorectal anastomosis. But again, I think you and the patient would have to have a very serious conversation about what the expected outcomes might be. So then for our next case, we have the same SITSMARK study, but now all of your markers are in the pelvis. And here we have our defecography. So if you're paranoid like me that your videos won't work, you put a still in there. And if you're relatively new to defecography like I am, or relatively unfamiliar with defecography like I think many people are, it's also helpful to have giant arrows that show what the problem is. So in this patient, the problem is pelvic floor non-relaxation. You can see preservation of the anorectal angle. And so for pelvic floor dysfunction, I would argue that the surgical correction for this is usually not surgical. It's usually biofeedback. So biofeedback does tend to work, as much as we may doubt it at times. So of 54 patients randomized to weekly biofeedback for 5 weeks versus Miralax and weekly counseling about constipation for 5 weeks, 80% of the biofeedback patients improved versus 22% of the medical management. And they actually had sustained improvement at 12 and 24 months. And they actually had improvements in straining and incomplete emptying and in abdominal pain. Similarly, in 77 patients who were randomized to biofeedback versus sham biofeedback, which I think would be very interesting to observe, versus medical management, the colonic transit improved in the biofeedback in the medical groups. Biofeedback improved pelvic floor relaxation, and the number of bowel movements and satisfaction were highest in the biofeedback group. So biofeedback does work well for this. And so for pelvic floor dysfunction, I think the answer is actually no surgery. It's to do biofeedback. If patients fail that and are miserable, another option, again, is an ileostomy. Sometimes, as Amy was saying, it's tough to motivate people to do biofeedback because they're looking for what's the cure going to be. So sometimes I actually mention up front that if biofeedback doesn't work, your other option is an ileostomy, and I think people find that pretty motivating sometimes to participate in biofeedback. So for our next case here, you have on the upper left normal, and then on the upper right, the beginnings of rectal intussusception. Bottom left, more rectal intussusception, and then in the bottom right, full thickness rectal prolapse. So rectal prolapse can be associated with constipation. So in Dahour's original report of ventral rectopexy for prolapse, 16 out of the 19 patients had improvement in their constipation. Similarly, in 59 patients who were undergoing a ventral rectopexy it was a mixture of patients with prolapse and some with intussusception, about 2/3 had improvements in their constipation. So does the actual surgery you perform matter? So in a randomized controlled trial of 75 patients with full thickness rectal prolapse, they compared ventral rectopexy to posterior sutured rectopexy. Both patients had improvements in their obstructed defecation score, and the degree of improvement was similar between the two groups. So it might not matter which operation you do exactly in that case. For rectal intussusception, with high-grade rectal intussusception, 20% have obstructed defecation, 20% have fecal incontinence, and most patients have a mixture of both. In general, ventral rectopexy seems to work well for this population also. So in a large sample of patients, rates of constipation decreased from 54% to 15.6%. And then similarly for rectal prolapse, does the exact surgery you're doing matter? So a systematic review and meta-analysis of 1,300 patients undergoing ventral rectopexy or resection rectopexy. So this is different. This is a resection rectopexy, not a posterior rectopexy like the previous slide. The ventral rectopexy actually had higher rates of improvement of constipation, which is great because you're also not having the risk of an anastomosis. And the recurrence rate, however, was higher for ventral rectopexy. So I think in this case, for rectal prolapse or rectal intussusception, the answer, depending on the patient, could be ventral rectopexy or a suture rectopexy. It's a quiz. So this one has a lot of stuff going on. So there's an interseal, there's a grade 3 to 4 rectal intussusception, there's a rectocele, and there's vaginal descent. So for multicompartment prolapse, previously we did a lot more sacrocolpopexy with a posterior rectopexy, and now we're doing more ventral rectopexy with sacrocolpopexy, or otherwise known as the sacrocolporectopexy, which is a little bit like Mary Poppins supercalifragilisticexpialidocious. It's a little bit tough to get out. So one of the earlier reports of this was 224 patients undergoing ventral rectopexy with permacol, which is not what most of us use, but there were 37 who also had vaginal vault prolapse and had a sacrocolpopexy. These patients had low rates of recurrence, and their constipation and fecal incontinence improved. Another study of 51 patients undergoing a ventral rectopexy with a sacrocolpopexy, and in those patients, everything got better: their fecal incontinence, their urinary incontinence, their constipation, and their sexual function. And so in these patients with multicompartment prolapse, I think the answer is a ventral rectopexy with a sacrocolpopexy. So this is the bonus round, which Dr. Thorson alluded to earlier. So you have both a grade 3 to 4 rectal intussusception, so a reasonable sized rectal intussusception, but you also have some pelvic floor non-relaxation. So I think in this case you need to tailor your treatment to the patient. So Dr. Thorson had talked about likely doing biofeedback first and then surgery. But I think in these patients, you have to think carefully about what's the main problem. When you examine them, does their pelvic floor not relax at all? In which case that might be the primary problem. Think about, are there reasons to try to avoid surgery? They're a poor surgical candidate with a lot of comorbidities. Is this a patient who can get to good quality biofeedback? I think this is a complicated situation where the average physical therapist might not do so great with this. So if you have a patient from Brainerd who is going to go back to their physical therapist up in Brainerd to try and get their pelvic floor to relax, this might not work out so well for them. And then also, does the patient have a preference about pursuing biofeedback versus surgery? I think most patients would probably prefer to do least invasive first and see if it works, but not every patient is that way. So I think for this, likely you're going to need both biofeedback and ventral rectopexy, but the exact order is very dependent on the patient. So in conclusion, surgery or no surgery for constipation has to be tailored to the anatomic findings on pelvic floor testing. Patients who have persistent pelvic floor non-relaxation after biofeedback, or those patients who have slow transit constipation have to be approached very carefully. And I think a good answer in this situation is a lot of times a loop ileostomy, which is much easier to reverse than a colostomy. And clinical judgment is paramount when there's a mixture of findings, such as a combination of grade 3 rectal intussusception with pelvic floor non-relaxation. Thank you.